enjoy being in Miami for 28 years, but now for the last year, I'm in Houston. But thank you. I am delighted to be with all of you. Many of you, of course, I know personally, and I look forward to seeing my good friends, hopefully, at the WFNS meeting, of which I'm the president later this month. And I think the theme will resonate with all of us who are globalists, who love the world and love peace and love everything else about friendship and family. And it is power of one, impact of many. And I'm delighted to have all the continental societies and their leaders there. And I'm delighted to have many of the national and regional society also having supplied speakers. And we have 24% of the attendees are actually from outside the US. So it'll be a phenomenally global meeting. There was a question earlier about what does it take to be a microsurgeon. This is my slide for it. You have to be a dancer to choreograph your aneurysm clipping. You have to be a warrior to deal with an AVM. It is truly a battle, as my good friend Mike Lawton said. You have to be an Air Force pilot to be stealthy strategist in resecting cavernomas, particularly in the brainstem, as Ugur said. You have to be an architect to think of complex bypasses. You have to be an endurance athlete for long, strenuous surgeries. And last but not least, and I don't know if the young people will appreciate what I'm going to say, you have to be a very good poker player to fool yourself and the audience in the OR when everything is falling apart, and you still have to keep the face of being completely in control when you're really not at that moment. So I think, so this is a slight summary of what we all need to be, or those of us who want to be a microvascular or a microsurgeon intracranially or in the spine for that matter. So having said that, I'm going to spend the rest of my 7 minutes just showing you videos of complex aneurysms being handled. This is an aneurysm of the pica, ruptured, coiled, recoiled, recanalized, sent to me by an endovascular, a very good endovascular neuroradiologist. You can see the acute angle of the inflow and outflow of the pica. So it wasn't obvious that I would be able to clip it, but of course that's always the best option. But what we ended up doing is the following. It's an end-to-end anastomosis through a simple retrosigmoid approach. So I want to show you, this is actually my fellow doing the dissection and doing a great job. But to show you, when you deal with coiled aneurysms, the torque can tear the neck. He's being very gentle, and he is proceeding carefully here, and very soon you see the rupture here. He didn't do anything, but notice he really didn't flinch. He was, I mean, he didn't jump, the hands didn't go everywhere. He put the temporary clip, and then I went in, I scrubbed in to help out, just to speed the video. I tried to clip it. It kept occluding the pica, so I decided the only way to do this is end-to-end anastomosis. So you can see the tear is right here at the neck. So I could not use the so-called cotton clip technique. It was too low. So we proceeded, opened the aneurysm to uncouple the coils from the neck, and then again tried to clip, wouldn't work. And there is the suturing. When you suture, you need to fish mouth. When you make an angle, 90 degree, you have to fish mouth or the vessel will kink itself. So that's the ICG. Patient did actually very well. Patent anastomosis and aneurysm excluded. Let's go to another one. OA P4 bypass for a coiled stent P2, P3 aneurysm. This is when I was still in Miami. And let me, 39-year-old with this, coiled, recoiled, stented, recanalized, sent to me for microsurgical treatment. I didn't think we could safely occlude and sacrifice the PCA. You have to study carefully the CTA. When you stent these patients, look how long the stent is. It makes, of course, life a lot harder for the microsurgeon. It goes all the way to the quadrigeminal cistern. So what is the best approach? I thought interhemispheric posterior approach, using gravity in your favor, and to do an occipital artery to P3, P4 bypass, and then endovascularly sacrificing the PCA the next day. This is such an approach. You get the occipital artery. Yeah, it can be tedious to dissect, but it's a basic technique for microsurgeon. Please notice I am mostly not using self-retaining retraction because I have a lumbar drain, and you cross with the bone flap the midline so that the sinus is not in your way. And actually, it's quite useful to use navigation, even though, of course, Ugur is right. There is brain shift, but it's important to get to the parieto-occipital artery as opposed to the calcarine artery, of course. And knowledge of anatomy naturally is important here. So here is the parieto-occipital artery. I'm going to put a gel foam behind it to make it a little easier to reach. I measure the flow with my good friend Fadi Charbel transonic flow probe, and I create a channel in the bone, in the skull, so the skin does not occlude the bypass. And it is a little deep bypass, but there is plenty of room. And then I'm going to do an end-to-side anastomosis in the usual way with a curved needle holder to add a wrist to our hand in a way. It's an extra degree of freedom. And I like to use running technique when I can. It's a little faster. And sometimes I mix running and interrupted, depends on the case. So that's a bypass done. And then the next day, as I said, I measure the flow. Of course, there is no need for the bypass yet. It's only 10 cc per minute, which is why we have to occlude the PCA. Here is putting the bone back with a nice tunnel, and that's the next day endovascularly occluding the PCA. Again, patient did very well. Here is the bypass. You can see it completely functional, and it's another good technique. Another case, I have 2 more minutes. I'll perhaps finish with this one. It's an 11-year-old boy presented with this syndrome and this very nasty double aneurysm. Look at this. It's really 2 aneurysms, the carotid blowout and an A1 blowout. And look at the A1 involving the ACOM. So, of course, I sat down with my endovascular colleague and tried to figure out what's the best strategy. So I decided for a high flow bypass with a saphenous vein to the M2 down to the neck, so that, and I occluded the A1 on this side, so that allows reversal of flow down the aneurysm, which did thrombose, occluded the carotid artery in the neck. And the next day, my endovascular colleague went from the other side and coiled the second aneurysm through the other A1. Again, we were very lucky. The patient did beautiful and no problem. You can see the bypass there, and again, didn't turn a hair. I think my time is out, so I should probably stop here. And I thank you for your attention.
You have 2 minutes, Jax.
Oh, I do? Okay. Thank you. I'll keep going then.
I will use it, Jack.
Sorry?
I said I will use it. Just
Well, yeah, you certainly need it. Okay, well, I'll finish with this one. This is a radial artery bypass to P3. Let me show you these tough aneurysms that have no endovascular
Do you share your screen, please?
solution. Oh, sorry, you're not seeing me?
Yeah, we're not able to see.
Oh, I'm sorry. Okay, 1 second. Okay, I'll just do it quickly again. And here we go.
We can see.
You see it? Yeah,
Yes.
okay. Very good. And let me take you this aneurysm, no endovascular option. Look at this beading of the P1, not stentable according to my colleagues who are all very good. Look at this nastiness. So I did an MCA to PCA bypass, intracranial, split the Sylvian fissure, and get this as a donor. Then take a piece of radial artery, go subtemporal, around the temporal lobe. I did have to lose some of the bridging veins. You're always worried when you do that. I'm trying to find a healthy P3 segment that is not atherosclerotic. This is the edge of the tentorium. And then I cut the tentorium. This is a good Hernesniami trick, all of you know, using a clip to reflect the tentorium. I do miss this man. He was really something special. Took the radial artery and sutured it to PCA. And anyway, I'll show you the final result here. And then the other end of it to the M3s. Here it is. That's the other side. Sutured it there. And then we proceeded with the endovascular occlusion. So it's like creating a PCOM for the patient using the radial artery. And that was at the end. You can see the bypass going around the temporal lobe and from subtemporal to transsylvian, measuring the flow, looks good. And that's the occlusion and thrombosis of the aneurysm endovascularly. Now I'm really done. Thank you very much for the extra time.